Hi, I'm Dr. Nicholas McManus, and I'm an emergency medicine physician, and welcome to my lecture on End-Tidal CO₂, the real sixth vital sign. In this course, we're not just talking about numbers on a monitor, we're going on an adventure. Think of it like a comic book story where heroes and villains battle for balance inside the human body. In Chapter 1, we'll unmask capnography, learning what it truly measures and why it's so powerful. Chapter 2 introduces our heroes, the lungs, the kidneys, and the red blood cell, the key players keeping our acid-based world in order. Then in Chapter 3, the villains rise, the imbalancers, the forces that disrupt that harmony and push our patients toward chaos. Chapter 4 is the story in the waveform. We'll learn to read every peak, plateau, and valley like clues to what's really happening inside the patient. And finally, Chapter 5, the endgame. We'll bring it all together in a real-world mega code case, watching the waveforms tell the story of life, death, and resuscitation. So buckle in. By the end of this journey, you'll see capnography not as a gadget or a number, but as a living, breathing reflection of physiology in motion. Since we're telling an epic story, it only makes sense to bring it to life. So let's get animated. Now that's more like it. I am the younger, better-looking version of Dr. McManus, and I will be your guide on our journey to master capnography. Every breath, every molecule, every shift in CO₂ tells a story. And our story begins with a single trace of smoke that changed medicine forever. The word capnography comes from the ancient Greek word kapnos, which means smoke. In early Greek culture, smoke was thought to carry the breath of life leaving the body. So when scientists began studying exhaled gases centuries later, they borrowed that word, kapnos, long before carbon dioxide was even discovered. The measurement of exhaled gas actually dates back to the 1600s, when a scientist named Jan Baptista van Helmont noticed that burning wood released something he called gas sylvestre. We now know that gas as carbon dioxide. Fast forward to World War II, capnography entered clinical medicine as a tool in anesthesia, helping doctors monitor ventilation during surgery. By the 1980s, capnography had become a standard of care in operating rooms, and today it's recognized as a vital sign in both EMS and critical care, because it reflects ventilation, perfusion, and metabolism, all in real time. So when we talk about capnography today, we're really talking about how we visualize both inspired and expired gases in real time. In the context of anesthesia, that means measuring carbon dioxide at the point where gases mix, whether that's at the Y connector of the ventilator circuit, through a mask, or even a nasal cannula. Every breath in and every breath out tells us something about the patient, how well they're ventilating, how effectively they're exchanging gas, and sometimes how well their heart is even pumping. In other words, capnography gives us a real-time picture of what's happening inside the body, one breath at a time. Capnography isn't magic, it's physics. Every gas absorbs light in its own unique way, depending on the shape of its molecules. Oxygen, for example, primarily absorbs light in the ultraviolet spectrum. Nitrogen absorbs in the far ultraviolet spectrum, but carbon dioxide, it's different. CO₂ molecules vibrate at a frequency that perfectly matches a very specific part of the infrared spectrum, right here, just beyond visible light. So if we shine an infrared light source through a patient's exhaled breath, a mix of oxygen, nitrogen, water vapor, and carbon dioxide, every molecule except CO₂ becomes invisible to the detector. The more CO₂ that's present, the more infrared light gets absorbed. The monitor measures that change and converts it into a number, your End-Tidal CO₂ value, and then plots it as the familiar waveform we recognize on the screen. Pulse oximetry and capnography are both non-invasive ways to monitor a patient's respiratory status, but they measure very different things. This graph is called the oxyhemoglobin dissociation curve. It shows the relationship between the true oxygen concentration in the blood, that's the PaO2 along the bottom, and the percentage of hemoglobin saturated with oxygen, that's the SpO2, the number you see on the pulse oximeter. Notice the shape of this curve. It's not a straight line, it's an S shape. Down here on the steep part, small drops in oxygen pressure cause large drops in saturation. That's when a patient desaturates fast. But look up here, on this flat shoulder near the top, between about 80 and 100% saturation. In this range, big changes in actual oxygen concentration barely move the pulse oximeter reading. That means a patient can stop breathing or be hypoventilating and building up CO2, and their pulse ox still reads 97%. By the time that number finally dips below 90, their blood oxygen has already dropped dangerously low. So while the pulse oximeter tells you how much oxygen is on board, capnography tells you if the patient is actually moving air. It shows ventilation in real time, long before the oxygen curve catches up. After all that, here's what pulse oximetry can tell you about your patient. Hypoxia. That's pretty much it. It can tell you when your patient is already hypoxic, but it can't tell you why. It doesn't show you how well they're ventilating or whether they're retaining carbon dioxide. Pulse oximetry is valuable, but it's a single piece of the story. Capnography, on the other hand, can tell you much, much more. It shows you ventilation, how well air is actually moving in and out of the lungs. It confirms endotracheal tube placement and even differentiates airway obstruction from pulmonary edema. It helps guide sedation, showing when a patient is oversedated or undersedated. It reflects metabolic activity, ventilator function, and even cardiac output because the waveform changes with perfusion. During CPR, it tells you the quality of compressions, if your hand placement is effective, and whether return of spontaneous circulation is about to occur. It can help you monitor ventilation during a seizure, track a patient's response to albuterol, or even predict cardiac arrest outcomes. So while the pulse oximeter tells you if oxygen is on board, capnography tells you how the entire system is working. It's not just a monitor, it's a window into the physiology of your patient. Here's one of the biggest differences between pulse oximetry and capnography: time. When a patient stops breathing, capnography shows it almost immediately. Within just a few seconds, that waveform disappears and the number drops. But the pulse oximeter, it keeps smiling at you for a while. In fact, it can take up to 90 seconds before the SpO2 begins to fall. That's a minute and a half of no ventilation before your monitor even tells you something's wrong. To put that in perspective, that's the length of someone singing the Star-Spangled Banner. So imagine a patient who's not breathing and your pulse ox still reads 99% for the entire song. By the time that number finally drops, you're already playing catch-up. Capnography doesn't wait that long. It shows the change right now, breath by breath, giving you the chance to act before oxygen levels crash. Now that we know why capnography matters, let's talk about what we're actually measuring. These two words, capnometry and capnography, sound similar, but they mean slightly different things. Capnometry refers to the measurement and numerical display of End-Tidal CO₂. It gives you a number. That's it. There's no waveform, no context, just a single data point on a screen. It's measured by a capnometer. Capnography, on the other hand, gives you the whole story. It displays both the numerical value and the waveform, showing the rise and fall of CO₂ with each breath. That waveform adds depth. It shows you how the patient is ventilating, not just the final number. So in short, capnometry gives you a number, capnography gives you insight. There are two main ways we measure end-tidal CO₂, mainstream and side stream. On the left is mainstream. This method places the sensor directly in the breathing circuit, right where gases pass in and out of the airway. Because it's measuring CO₂ in real time, breath by breath, it gives you very fast and very accurate readings. The trade-off is that it's invasive. You have to be intubated or on a ventilator to use it. On the right is side stream. This uses a small sampling line that pulls a tiny amount of exhaled gas from the patient and sends it through tubing to the monitor. It's not invasive, and that's why we use it most often in the field with nasal cannulas or masks, but it comes with a slight delay and is a little less accurate than mainstream. In short, mainstream gives you precision at the tube, side stream gives you versatility anywhere else. A normal end-tidal CO₂ measured by capnography is 35 to 45 millimeters of mercury, and a normal carbon dioxide level in the blood is the same, 35 to 45 millimeters of mercury. Under normal physiology, these two values are very closely related, but not identical. The end-tidal CO₂ that you see on your monitor usually falls just a touch lower than what is actually going on in your patient's blood, about 2 to 5 millimeters of mercury lower. But still, these values are pretty close. That small difference exists because the air we exhale at the end of a breath contains a little bit of gas from dead space, areas of the lung that are ventilated but not perfused. Since no gas exchange happens there, that air is slightly diluted in CO2. As long as perfusion and ventilation are normal, this gradient stays narrow, tight, predictable, and physiologic. But when it starts to widen, like in shock, pulmonary embolism, or severe ventilation-perfusion mismatch, it's an early clue that something's wrong with either perfusion or gas exchange efficiency. That's what makes End-Tidal CO₂ so powerful. It doesn't just tell us about ventilation, it tells us how well the whole cardiorespiratory system is working together. Now let's take a look at what the waveform actually means. It is a visual representation of carbon dioxide concentration over time. Now right away, you are probably thinking that this looks a lot like a ventilator waveform, but it's not. A ventilator displays pressure or volume over time. Capnography, on the other hand, shows gas concentration, specifically the amount of carbon dioxide present at any given moment in the breathing cycle. Let's break it down. The waveform begins here at phase 1, this flat baseline. The gas being sampled here is dead space gas. It's air that's been in the conducting airways but hasn't actually participated in gas exchange. That's why there's essentially no CO2. It reads close to zero. As exhalation begins, we enter phase 2. This is the sharp upstroke where dead space gas mixes with gas from the alveoli. You're now starting to see CO2 levels rise rapidly. Then comes phase 3, the alveolar plateau. This portion represents gas coming purely from the alveoli, where gas exchange is happening. The CO2 levels off into a gentle slope, reflecting uniform alveolar emptying. The very peak of that plateau, sometimes labeled as point beta, marks the End-Tidal CO₂, the highest concentration of exhaled CO2 in that breath. This value most accurately reflects alveolar CO2 and is what we use for monitoring. Finally, as inspiration begins, fresh gas is drawn back in. The CO2 concentration drops straight back down to baseline and the cycle repeats. So remember, this isn't a measure of pressure or volume, it's a direct window into ventilation and gas exchange, captured one breath at a time. And that's just the beginning. In the next chapters, we'll meet the heroes keeping the body in balance and see how each one fights to maintain equilibrium when physiology starts to fail. You can watch the full lecture on our website. There you'll find the complete End-Tidal CO₂ series, interactive quizzes, and additional training content designed for EMS, emergency medicine, and critical care providers. If you enjoyed this lesson, subscribe to our channel for more content on the science behind emergency medicine and how to see physiology in motion. I'm Dr. Nicholas McManus. Thanks for joining me, and I'll see you in the next chapter.